Hello, I'm Dr. Jonathan Silverberg. I'm a professor of dermatology and director of clinical research and patch testing at the George Washington University School of Medicine and Health Sciences in Washington, D.C. The treatment landscape for atopic dermatitis has evolved enormously, and now we have therapies that are more effective, more potent, faster in their onset of effect, and really change our perspective on what we can accomplish with different therapies. And with that, our hopes and our expectations for treatment efficacy are increasing and improving. So when we look at how the bar has shifted, we're also watching as these treat-to-target guidelines are shifting with that and are changing our sort of hopes and our goals there. Now, one such example is a recent MDA criteria that has been developed for atopic dermatitis. And what is MDA? MDA stands for minimal disease activity. This is a version of the treat-to-target approach where the idea is maybe early on you'll have more moderate endpoints, but what you really want to achieve is as clear as possible, right? You want to be able to improve holistically all of the different domains, get them to the lowest possible scores for itch and for lesional clearance. And in the case of atopic dermatitis, skin pain, frequency of symptoms, mental health symptoms, improving their own perception of disease severity, etc. So minimal disease activity says, don't just ask the patient. One of my pet peeves is a lot of clinicians will go into the room, they'll ask the patient on some medication, how are you doing? The patient says, okay, and then they exit the room as quickly as possible so they can get out of there. And the problem is you have to follow that up and ask, how are you doing really? Are you fully controlled with itch? Are you really fully controlled with sleeplessness? Are you fully controlled in terms of new lesions? Are you really reducing flares? And so it's important to try to build this in, probe a little bit more, understand just how deep of a response they're getting. Now, this particular minimal disease activity criteria that has been developed for atopic dermatitis, it builds that in. It gives you those targets. But what I particularly like about it is it also fuses the treat-to-target approach with the idea of shared decision-making. One of the challenges of a lot of the different treat-to-target approaches is they come up with this sort of one-size-fits-all, here's what you should aim for in every patient, as if every patient is exactly the same or every patient has the exact same concerns. And of course, that's not true. With this shared decision-making approach infused or combined together with the treat-to-target approach, the dermatologist or the clinician will ask the patient, what matters to you most? What's bothering you the most? What do you want to improve the most? And then if they say, for example, well, I really need to sleep better and I need to get the itch better. Well, then there's a list of how to measure itch and sleep in a standardized fashion and what those targets should be. So now you've set the targets based on this treat-to-target approach and for what matters to patients. And this is something that really resonates with patients. It allows you to ask and address and monitor with treatments the specific domains that matter to patients and less of the ones that don't matter as much to patients, but still, in the end of the day, trying to get those more robust endpoints achieved.